Basically, this session we are starting. This is basically for diabetic retinopathy. On one hand, we will be talking about diabetic retinopathy, various aspects like macular edema, what are the clinical steps, what are the other features. And on the other hand, we will be talking about the human analog. So this has been crafted in such a manner. I want to go to the next slide. Yeah. So basically, we will be listening to Dr. Avijat, who will be sharing his what has been our previous experience. We have been working on this human analog for almost now 5 years. Dr. Rajiv will be talking about screening strategies. What is the current role of AI? Then there will be Dr. Ajay Didani correlating investigations. Chawla sir will present on DME management in a case-based scenario. Dr. Luthra will be talking about intravitreal. They will be joining us. Lasers in DME by Dr. Vinita. And then Professor KJ Singh will have his final word. This is what we call as human analog. Now, what is human analog? It is getting the things done by human resource, what we want a computer to do. So what we want a software to do, if we are getting it done by human beings, that is the human analog. In artificial intelligence, basically what we do, we use picture, we divide into arithmetic expressions, and then we reform a picture. So a picture, a dog is recognized as a dog or a fish or a cat. So computer will be able to identify a normal retina or a diseased retina. Basically, AI remains a screening tool, and the purpose is to identify treatable diabetic retinopathy. And now it has been extended to prognosticate various aspects of the disease. What we need to understand is that human analog, like AI, is also primarily a screening tool only. When we teach our students, we teach them in a very complicated way. We teach them so many classifications. We give them, but when we talk about computer, we give them a very simplified picture, which is very easy to identify. So if we can get such simplified things as we tend to occur as we understand in the natural course of disease, then things will become very easy for our HR to identify. So this is the IDX platform, which uses this criteria, which is known as MTM diabetic retinopathy. If your picture is matching with this picture, you will refer it to an eye care professional. If it is negative, the AI will say that you come after 12 months. And this gives you a 90% sensitivity or specificity. But they are using a criteria which is level 35 or higher of the ETDRS chart. So basically what we understand is that AI is based on picture recognition and interpretation. In this presentation, which has come in February 23 only, what we understand is that when we are interpreting a picture, manual interpretation is as good as a computer generated interpretation as far as image identification is concerned. So what is human analog? A human analog should have a simplified identification criteria, an easy to handle tool, a simplified achievable target, and if we have this much, then our outcomes will be predictable. So what we are doing in AI, we are simplifying it, we are standardizing it, and then we are reaching to a high sensitivity. If we do the same thing for human thing, then our results will be equally good. So we have decided, earlier we decided that we will use VTDR as our referral point. So in VTDR, as we know, there is a 4-to-1 rule. There is either we have neovascularization or we have preretinal hemorrhage, vitreous hemorrhage, or macula involving center or not involving center near. So these are the features of VTDR which we were using for identification. But if we use VTDR as a reference threshold, then the sensitivity is moderate. Although our referrals are more specific, specificity is high. And referrals will be more appropriate. But we need higher level of training in identification because things like IRMA and beading are very difficult to identify. So we need to relax the referral criteria. So what has been done in various AI modules, they have used this ETDR as a scale which matches. So this is more than mild diabetic retinopathy and this is the VTDR thing. And what they are using is more than mild diabetic retinopathy as their referral feature. So if we relax our feature from VTDR to MTDR, then our pick rate will become very easy. Our training will become very easy also. What has been shown that if we do a screening of diabetic retinopathy, then preventable blindness or the blindness induced problems will go down significantly. In 2020, interestingly, WHO guidelines have come for screening, and what they are saying is very interesting. They are saying, WHO is telling that screening can be carried out by family doctors, optometrists, ophthalmologists, physician, endocrinologists, internists, residents. So they have not left anybody. And what these human resource should do, they should be trained to examine the eye. Either they should be trained to examine the eye, and if it is difficult, then they should be able to interpret a picture. So that is what is WHO guideline in 2020. That is precisely what we are saying, but we are saying it from now to 2017-18. And that is what we call as human analog. Recently in 21, Rajiv Raman has come out with a famous article in IGO, and it has certain points. And the point which I took it out of it, that there is a need to strike a balance between what is universal or what is ideal and what should be done. For example, if we screen the whole population, that is ideal. But if we screen only the diabetic clinics, then that should be good enough. So where we are, we understand that preventable diabetic blindness is a significant challenge in India. Screening activities reduce the incidence of visual loss. That is what the European experience has also said, and that is what the WHO report also says. VTDR we took as the standard threshold for referral, and now we have reduced it to MTMDR. So we are using the same criteria for human resource training, what they are using for AI. So in order to evolve the AI thing, what has been done, the disease has been simplified, the classification has been simplified, and the criteria has also been simplified. So for sake, we are using MTDR, that's a good alternative criteria for referral threshold. And human analog, therefore, is an important tool to handle the wrath of preventable blindness, especially in our context where human resources in plenty. It's also a viable standard alternative to diabetic retinopathy. Thank you. Now, I will ask Dr. Abhijat to share what we have achieved in last few years. And then Rajiv Raman is not here because his father had some problem. So he has given me his PPT and I will share. He will be talking about AI in screening. That will be a very nice comparison. And then we will have future presentations on diabetic retinopathy. कर दिया?
display. So, okay, good afternoon, everyone. I will be briefly taking you through the previous experiences and outcomes of our program. So, we started this program in the year 2018 with CME with a difference in coordination with the Kanpur Ophthalmic Society. Briefly after that, it was presented for the first time in the state level in the Uttarakhand State Ophthalmic Society. After that, a small exercise was conducted among the postgraduate students. Yeah. So after that, a short exercise was conducted among the postgraduate students of GSVM Medical College Kanpur. And after the success of it, we, for the first time, presented this entire program at a national level. And we have been doing that since the year 2020 at Gurugram, Mumbai, and even in the virtual AIOC. And currently, we are presenting its next version here at Kochi. So between these times, we have also conducted various online surveys about which I'll be telling in the further slides. So how it all began. So there was a reality check that is artificial intelligence an accessible possibility in the setting of our country. And there was evaluation for need of artificial intelligence for the purpose of identification of treatable DR. That whether we actually need AI or could this be done by even human resources. So we needed to teach ophthalmologists the identification of treatable DR, and we needed to simplify this procedure of identification so that referral could be done. So we need to look in the future and we need to make some decisions. For that, in the very beginning, we need to identify what should be the referral threshold for each and every ophthalmologist. And we need to standardize this entire concept and therefore present it at a mass level. So in the year 2020 at AIOC conducted in Gurugram, for the first time we presented it at a national level and where we introduced the basic features of diabetic retinopathy. After that, we gave voting pads to the audience and conducted an on-spot voting. So the goal was to conduct an interactive session and obtain a live analysis from it. So the basis of the course was basically a vision-threatening diabetic retinopathy features. These were chosen. And to simplify the entire criteria, we used the ICO guidelines, and the basis was diabetic macular edema involving center or not, rather than CSME. So the training was done in 2 steps. In the first step, they were shown simplified photographs of DR, and the voting was conducted. And the response of the entire audience was recorded. A random selection of strata was done so as to mandate any sort of participation. So this was the sample slide. We just showed the slide for 30 seconds and asked the audience that, is this vision-threatening diabetic retinopathy? Everyone was given 3 responses, yes, no, or cannot be commented upon, and then the voting was conducted. So this was an example of a response which was recorded where around 54% people said that, yes, this is vision VTDR, and there were 25% with no and 21% who said that this cannot be commented upon. So the responses after showing around 10 to 15 slides were erratic in nature, and there was a state of uncertainty and doubt. So after this, we introduced the basic criteria of ICO. Then we again showed some pictures of disease patterns like macular edema, vitreous hemorrhage, NVD, NV, etc. Again, we showed the VTDR characteristics, and the entire process of voting was recorded once again. After this, after the second round of voting, we saw that there was a very predictable outcome. The mandate was pretty clear in the clear cases, and hence we needed to upgrade the decision-making capacity of all the ophthalmologists. But there was a moderate sensitivity in the borderline cases, so we needed to work on that. So VTDR was definitely a reference threshold after this entire session. And the target audience was non-retina ophthalmologists. The limitations of EI were also demystified, and the objective and scope of human analog was better identified. After this, we conducted few online surveys in May 2021 and in November 2022. Responses of 23 and 58 participants respectively were recorded. So before recording the online survey, we showed them 2 slides where we showed the VTDR characteristics. And in the above slide, we showed them about the 4-2-1 rule also. And below we showed that what are the different features of vision-threatening diabetic retinopathy. After that, we conducted such an online survey where again we showed the images of diabetic retinopathy and gave them 3 responses, yes, no, or can't say. So this was the responses that were recorded in both the online surveys. So after recording such responses, again, we could say that the mandate was pretty clear in all the clear-cut cases. This was the latest random online survey, which was conducted in March 2023. And for the first time, we recorded a response of 100 ophthalmologists, which were all randomly selected. And a similar response was recorded as before, but on a larger scale. So these were the answers when compared from the 2020 to 2022 sessions. So we can see that the correct answers are 60% and 70%, which is expected after teaching them something. But there was still something which was wrong answers were 20% in the year 2020, which we tried to improve in 2022 after even educating more. So the wrong answers came down to 0%. But still there are around 20 to 30% population who cannot decide that whether this is referable case or not. And now we think that VTDR is the thing which is creating some confusion. So in order to resolve this confusion, we think that MTMDR, which is more than mild diabetic retinopathy, is a better option than VTDR. So if you find something which has diabetic retinopathy and you cannot decide that we need to refer it or not, it's better that you refer the patient. So if we follow that MTMDR criteria, this divided population, the number which is there, the 20% and the 30% population, this directly gets added to the correct answer population, and the positivity rate increases directly to 80 to 90%, therefore increasing the referral capabilities. So as I said before, in clear-cut cases, everyone knows what to do. In borderline cases, rather than considering vision-threatening diabetic retinopathy, we should consider more than mild diabetic retinopathy, and this would increase our positivity rate and would also increase the referral capacity of the ophthalmologists. So in current scenario, human analog can be considered a very important screening tool for diabetic retinopathy referral, and this would combat the load of diabetic blindness in our nation. This would also be very good opportunity for availability of prompt and affordable services in the remote parts of our nation. Thank you so much.
That sensitivity and specificity is even that the participant dependency also.
Yes,
So
yes.
when you are comparing 2020 to 2023, the participants should have been same. Only you can conclude, otherwise every time you are go on changing the participant, an IQ level of participants will be different.
Yeah, that is there. That is there.
So, Kamalji sir, come on the stage, sir. Chawla sir, please come on the stage. Okay. So here is the next presentation is by Rajiv Raman, and he has given me this slide, and I'll share in short what has been done by Rajiv Raman. This is very good work of Dr. Rajiv. And yeah, can we move on the slide? So basically, The difference, what AI can do in diabetic retinopathy is there is some repetitive tasks, which he says that if doctors are not having much time, so they can identify, AI can identify. But there are some things which doctors cannot do, and that is prediction and of the disease. So AI can do screening, it can diagnose stages of PDR, and it can also classify OCT abnormalities. But the thing which is new, which has come out, is predicting about the disease progression. Also, response to the treatment, which can be predicted. And that is what he has worked on. So, as of now, according to him, it is a screening tool and also helps in prediction of response of the treatment. So what are the screening guidelines using AI, and how predictive, how good the algorithms are? So as the American Diabetic Association says, that artificial intelligence can be used as a predictive tool, and the benefits can be used. But where AI is not to be used is if the patient is a known case of diabetic retinopathy, if there is a prior treatment, or if there is visual impairment. That's the article which I was referring, and what point he has made here is that it is empirical for ophthalmologists to grade all the identified referable photographs of AI by human beings in India, because 10% of normal are also referred. So that is the consensus criteria about AI. What is the accuracy of algorithms? And he compiled 10 articles which have used various criteria, like various grading criterias, and they have come out with various sensitivities and specificities, which range from, say, 50% to nearly 92%. And what he says that they are reasonably good. So this is the current status of various algorithms. And how SN is using, so there is an assisted mode where an eye doctor is given photograph, for example, an anterior segment specialist, or it can be done where the doctor has no knowledge about diabetic retinopathy and he has been given photographs and AI is assisted. And this is the video which shows how the work is done there, EMR based. A consent is taken, and then ultimately through the record a photograph is presented, and that photograph is being examined, and after examining, the classification is done by AI. And then also a doctor gives his opinion. For example, here it is mentioning a stage, and AI is mentioning a stage. So either what AI as of now can do in diabetic, so diabetic macular edema can be either handled by human resource, which is manual learning, or it can be used through machine learning. Whereas the additional thing which is coming out is predicting the responses of the disease. So here the thing is he is using OCT to predict whether the response will be there or will not be there of a particular patient. And this is the sequence of event that EMR से question generate करते हैं, फिर उसके बाद data को analyze करते हैं, then optometrist validate करता है, then there is some other questions asked, and ultimately OCT is done, and the data is generated. So a huge data is processed into a small data, and then there are certain criteria which are used for diabetic retinopathy, and then it goes to machine learning, and then a prediction is generated. This is quite interesting, that as the disease progression goes on, the regression becomes more linear. So that means what AI is predicting and what human beings are predicting, they are going hand in hand. That is what I could interpret out of this slide. This is quite difficult slide actually to interpret. It is somebody else's work. The other thing is, other good thing which has come out of this study is using biomarkers and then predicting a score, making a score of diabetic retinopathy, and then using that score as a criteria for prediction of the outcome. For example, the inflammatory biomarkers have been used. For example, thickness, cystic degeneration, hyperreflective things, whether they are involving the center or they are not involving the center, whether they are involving the outer layers or the inner layers, a classification is generated, and that classification has been given a color, and you can have an overview of your severity by just looking at the scale. And then ultimately a score is generated. This sounds pretty good, and I think a lot of energy must have been given, and what I interpreted out of this slide is that gives you a pretty good accuracy and precision. And this is a small video where he is trying to show how this is actually a self-explanatory thing where AI is actually identifying that these are the features, and then ultimately a score is generated, and out of this score so these are the criteria for hard exudates, intraretinal cyst, microaneurysm, cystoid macular edema, and an inflammation score of 65 is generated, and which predicts that severity is very high and this may not respond to anti-VEGF. So that is one interesting outcome of this particular entire big exercise. Sounds pretty interesting. So what is the take-home message? That it is a diabetic retinopathy is a screening tool. Simultaneously, we can screen other angiopathies, and ultimately it can be used as a predicting tool for outcomes. And that is what is the chart of evolution. So I thank Dr. Raman for sharing his slides. And I think, may I call Dr. Gajen Chawla sir to make his presentation, case-based scenario. I will make a video of yours. उस पे जाना है.
Can I start? Malay sir, can I start? Ji sir, we'll do that. First we'll finish with this IC, and then probably we'll talk about in the future what we should do. So thank Dr. Malay for giving the opportunity. As you know that because of the change in the lifestyle, food habits, the number of diabetic patients are increasing, and so the patient with the diabetic retinopathy and maculopathy. DME is a multifactorial disease, and so the treating DME always remains challenge to the retina specialist. Since ETRS studies, focal and grid laser has been the mainstay of the treatment, but with the recent advances in the about 2 decades like OCT and intravitreal pharmacotherapy, that has changed the management of DME, and now we retina specialists are aiming for the vision improvement rather than the prevention of the vision loss. So, DME can be classified as a non-central, central and tractional macular edema. And there are various treatment options are available, like ranging right from the metabolic control, the laser, intravitreal pharmacotherapy, and combination of the various treatment. There are several randomized control trial has been available in the literature to evaluate the retinal laser, intravitreal, anti-VEGF and steroid treatment, and a guideline has been published in the literature right from the American guideline, European guideline and the Indian treatment guideline, about which Dr. Malay was also referring to. I will be sharing few of my case depend on guideline how do we treat and what should be the treatment protocol for the various patients. This is the first case of a diabetic retinopathy having the poor vision with the poor glycemic and systemic control. The HbA1c was 9.7. He was presented with this scenario. There was a hard exudates and there was a CSME. Vision was compromised. We have asked for a this was the angiography, shows the confirming the finding. OCT also shows the hard exudate beneath the macula, and there was a CSME not very significant. CMT was not very increased in the right eye, but left eye was bit better, bit more. We have advised for the strict metabolic control and kept patient under observation. We have discussed the pros and cons about the, we have advised the anti-VEGF, but patient was, because of some reasons, was not ready for that at a particular time. But then we kept on the metabolic control. After 4 months when he came to us, his vision was improving and the systemic control with the only that exudate was decreasing. And he had a good vision even after the 4 months of strict metabolic control. Sometimes it may take little longer period to resolve this macular hard exudates and macular edema. Another patient having with the only strict metabolic control, the diabetic maculopathy has been improved within 9 months. There are certain clinical situations. There is one clinical situation is non-central macular edema with a good functional vision. Here again the first criteria we always keep is a good control of systemic conditions, and focal laser was advised, which was done, and within 6 months the result is good. Another patient with which undergone the laser therapy, and just within 5-6 months that CSME has been improved. There is a another clinical situation when central involved macular edema with good visual function. If vision is good, 6-9 are better, and if patient is asymptomatic, one can observe with the close follow-up and with the good metabolic control, it should be advised every time. When in follow-up if there is a increase in the cystic species or there is a decrease in the vision, one can start the anti-VEGF therapy. This is one case of 50-year-old male, had a diabetic and had a IHD. He underwent PRP elsewhere and vision was good. This was the angiogram that showed the residual NV and CSME. This patient, because there is a OCT shows the CI macular edema, but vision was good, so we decided to just do a fill-in PRP for NVE and the kept patient under follow-up. He is under follow-up since last more than 1.5 years, like from November 21 to last follow-up last week. He is still maintaining good vision without any anti-VEGF injections. But if vision is compromised, certainly we have to go for a treatment, and anti-VEGF is a good choice or a first line of treatment, especially in the phakic eye, because of the risk of IOP and cataract formation with the dexamethasone steroid implants. There are a number of VEGF is available. The options are available with us. How many injections? It is again various studies suggested the loading monthly injection with anti-VEGF followed by PNR or treat and extend protocols. One patient of 53-year-old female with a poorly controlled diabetic, she is also underwent PRP. Her vision was 6-12 in 8 and having a grade 1 nuclear sclerosis. The angiogram shows residual NVE, minimal CSME, laser, and there was a laser mass. OCT was showing no macular edema, so we did complete the PRP. But when she came for follow-up after 3 months, there was a CSME and central thickness increased, so we have given anti-VEGF, Resumab, 2 injection was given, and the patient was, the situation was improved, and she is maintaining good vision and good OCT. Another patient with severe NPDR with CSME. This patient was given aflibercept in August, and the second dose was given in October, just after 1.5 months. And patient has received 4 injections, but there was no improvement in CME. CSME was cystic spaces was persisting. I don't have that. I missed that one angiogram of February where the cystic spaces was increased. So we have given the we have given Paginex, and after that, that patient has improved. Another patient of having a poor vision with a good cystic spaces has received 3 eccentric injection with the condition has improved and the patient is maintaining good vision. This is another patient which has received recurrence DME. He has received multiple ranibizumab initially. Now he is on intravitreal aflibercept on PRR basis. You can see that in August we have there was a cystic spaces. We have given injection. He was improved. Again reappear in February 22 with another injection has improved again. Again in August 22 there was a recurrence of cystic spaces, macular edema, and we have given another injection. The intravitreal steroids is again there are evidence suggested that the inflammation in addition to VEGF plays an important role in the DME, but because of the risk of raised IOP and early cataract formation, it is used in the recalcitrant cases. This is one case that lady I have shared earlier, the other eye of that lady with the poor glycemic control. She has also undergone the PRP in this eye. This is the FFA shows the pre-retinal hemorrhage, diffuse edema. But on OCT there was a very minimal spaces here. So we have decided only to go for a laser in March 22. We have completed the laser and she was under follow-up. And in August, when she came after 5 months of our laser, there was an increase in cystic spaces and there was a early neurosensory detachment. We had given the anti-VEGF Resumab. There she has received 3 doses, but she was not improving her cystic spaces. That CME was persisting, so we decided to go for Ozurdex because this eye was a pseudophakic. So we have a plan for Ozurdex, which was given in the January 23. After 3 months, when she came for follow-up, her situation was improving. There is another patient who has received Ozurdex. The CSME has decreased. This is one 25-year female. Unfortunately, she was diagnosed just diabetic in 2 years back and was having a retinopathy. She underwent PRP elsewhere, and when she came to us, she was having a PDR with TRD. OCT in right eye shows the gross CME, but with the extrafoveal traction. Since the fovea was not involved, so we have waited for, we have decided we can try with Ozurdex because there were some issues with the anti-VEGF because of some systemic this thing. So we have decided for the Ozurdex. And see, this patient we have given in June 2018. After 1 month, there was a CME after this 1 month post Ozurdex, and gradually, if you see, after say about 6 months, her condition was improving because her condition of systemic condition was also improving. There was mild hemorrhage here and there, but still that central fovea is good, and she was maintaining good 6/18, 6/12 vision. Triamcinolone is another option for the as a steroid. We can give anti-VEGF, although the most of the guidelines, including the Indian treatment guidelines, they are silent on the use of intravitreal triamcinolone. But in our scenario, because of the patient comes from the low socioeconomic status, we are using triamcinolone 2 mg, not the 4 mg which was earlier used in the various studies. And we are combining with the laser once CMT is decreased. There is a raised IOP was observed in 12 to 14% patient, which was controlled with the topical anti-glaucoma therapy, and the surgical treatment was required only in the 2% of the cases. This is the one patient we have initially asked for the systemic control. The hard exudate was gone in 7-8 months, but there was a still macular edema was there. So we decided to go for IVTA, and after 1 month of IVTA, patient was improving, and this is after 6 months of IVTA, the vision improved to 6, 12 and 10. In spite of so many options we are having, so many trial and error we are using, but there are certain patients they don't respond much, and it is very difficult, they are challenging. This particular patient is under my follow-up since last almost 7 years, and he has received more than 25 procedures, including eccentric, laser, Eylea, Azurex, whatnot. And in the last this thing, November 21, here, from here we have started on Paginex. Although at that time it was not approved for DME, which is now approved, but since he was because 7 years he was become my friend, so I had discussed with him all pros and cons and given the Paginex, and now he is on PRN Paginex. Every 4 months, 5 months we have to repeat the injection. There is last situation where we should talk about the macular edema with the traction. Vitreous surgery is the only choice, and this is one patient which had a CME which was increased. We have given the multiple injection. The hard exudate with the systemic control was decreasing, but that macular edema cystic spaces was persisting. In due course of the time, patient developed vitreous hemorrhage, and ERM we decided to go for a vitreous surgery, and that after the vitreous surgery the things has been stabilized. Another patient post laser, not much of clinically significant macular edema on clinical picture, but vision was not improving. When OCG showed there is a tractional element, and we after the surgery has been stabilized. To conclude, the better understanding of the pathogenesis, newer imaging technique, and the number of options available to treat improvement of vision is possible in the patient with DME. A strict control of diabetes and other systemic condition is very important. Early diagnosis and prompt treatment is the key. Non-central involved DME, laser is the treatment of choice. Anti-VEGF has established the first type treatment, and intravitreal steroid can be considered as the first line therapy in pseudophakic eye or vitrectomy eyes. In presence of VMT, vitrectomy has to be done. Thank you so much for the patient sharing.
Sir, Chawla sir, where would you use laser in macular edema?
Sir, if you ask me, I think Vinita is going to talk about this particular subject. Yes, it's extrafoveal, definitely it is there. If you ask me, in my practice, because and I should say because my patient group is not very highly paid, except this 1 or 2 what I have shown in multiple injection, because he was having the reimbursement facilities, so probably he's tolerating all the expenses. I give a loading dose if there is a central involved macular edema and poor vision. Once CMT decrease, I do a laser.
Great.
I do a laser in my all cases.
Great.
Although the literature is very controversial and doubtful and very debatable.
See, what is important is that we should have our own point of view. Yes, sir.
So basically metabolic control is very, very important, and in the past perhaps when the days of intravitreal injections were not there, all the specialists used to say that one must do a metabolic control for at least 3 to 6 months, then embark upon the injections. And it's not a acute process, diabetic maculopathy. And if we control all these things, these edemas, they subside, the heart exudates, as Dr. Saab has shown, many of them have gone after good control. So that is also very essential. And as he has rightly said that all cases in Indian scenario, I am working in a government setup, I have been doing laser photocoagulation for almost now 30 years. I find that supposing in 100 patients, I hardly find patients coming back for injection in time. They would come after 6 weeks or maybe 3 months कि सर वो एक इंजेक्शन लगाया था, अब फिर हमें कम दिखने लगा तो अब लगवा दीजिए. So that problem is there. Secondly, our physicians, they don't have a direct, you mentioned that there should optometrists, physicians, clinicians, and everybody should see the fundus. Our physicians, in good old days, our Professor Mittal used to do fundus examination himself in all cases of hypertension and diabetic retinopathy. But today nobody does. And they are hardly bothered about eyes. So it's very important point that they should be told, they should be taught, and education should be proper so that they also see the fundus, and when they should refer, that is important. Many a time they are not bothered. If the vision is good, they would not refer. Even if there is PDR and macular edema is not there. So artificial intelligence is very good, as you have already mentioned, but facilities don't exist in our country. So we have to train our residents, the physicians and the ophthalmologists also for examining the fundus. That is very, very important.
So young retina surgeon is sitting. अपना नाम बताइए और अपना opinion बताइए. How are you treating diabetic retinopathy in your scenario?
Sir, I'm Dr. Pranav.
Yeah, Pranav, yeah.
Yes, sir. Actually, sir, it's almost similar to what sir said, but we don't laser usually. Especially in Chitrakoot, we wait for at least 6 months. We prefer shifting to Ozurdex, but again the same problem is that most of the patients are not affording. So that is a big problem in our scenario also. But if we counsel the patient correctly, most of them somehow get the injection done. And if we counsel them that Ozurdex works for around 3 to 6 months, and it will cost almost similar to other drugs. So in that cases also, like lots of patients take the injection, and we've seen very good results. Most of the patients presenting to us are already either proliferative diabetic retinopathy patients, and either they have hyperreflective foci and EZ loss. So we can go directly for Ozurdex also in these cases, or IVTA. If the patient is, even if he is phakic, we prefer going for Ozurdex because we've seen that most of the patients don't develop cataract soon. But IVTA in all the pseudophakic eyes, we can go for that. And otherwise, anti-VEGF is for the patients who freshly come to us. Focal and grid laser, we don't do in Chitrakoot. Very rare in very recalcitrant macular edema cases. Only in those cases we go for that.
So what do? You keep calling the same patient again
Yes,
and
sir.
again and
Yes,
keep
sir.
injecting? How long?
Mostly, sir. We wait for around 6 to 12 months at least. If it's not, most of them resolve by itself. If they are not, then we can go for focal grid laser after doing a FFA.
What is your take, Dr. Vijay? You can use the mic there.
Thank you. So I have a different kind of thought process regarding the approach of DR. So for me, I like sort of a mixed approach. Like if there is some edema, I'll definitely see the metabolic control. That is very important, as sir said. But yes, if there is edema, I'd like to inject. But after like 2 weeks of injection, I will definitely go for a laser. If the stage is PDR or PDR with HRC, I'll go for a very tight laser PRP so that the thing does not recur. But it can still recur. And if it recurs, then we need to move on to a surgical option. But yes, according to me, I have seen in many cases in which I have lasered with very poor eyes, they became stable. More than that, in such eyes who had NVE, NV eyes, those patients improved after a very tight PRP and a very good PRP. But yes, injections have a role, and we keep on injecting also. We keep on adding laser PRP also. It's not necessary that we'll do just 3 sittings. We can do 5 sittings, 6 sittings, 7 sittings. So it is a very variable thing to say and to comment upon. Every DR patient is different. Even a single patient with DR in 2 different eyes will have a different treatment approach.
So 2 young consultants speaking differently, and here is Dr. Vinita Ramnani. She will talk about her point of view on the role of laser in diabetic retinopathy. Please come on podium. Podium is yours.
Thank you.
And I'll do the video for you. You do.
Good afternoon, everyone, and I would like to thank Dr. Malay and Dr. Chawla for giving me this opportunity. I will be talking about what is the role of laser in today's scenario. My slides are not moving. So, as being discussed, it is the leading cause of blindness in diabetes with prevalence which is more in type 2 diabetic, and it is 3% in 5 years, which goes to 28% when it becomes a 20 years of type 2 diabetes, while in type 1 diabetes it is around 27% down the line of 9 years. As being said before, according to ETDRS, we call it when there is a retinal thickening within the 1 disc diameter from the foveal center with 2 disc diameter wide, or there could be a various classification as being discussed before. It's a focal macular laser with an hard exudate with a leaking microaneurysm in the center, or it could be a diffuse edema which is due to the larger breakdown not only of a microaneurysm but also the capillaries, which shows an extensive leak on FFA, and the center involving and non-center involving, which is an OCT classification involving 1 millimeter of the central zone are outside. And then clinical significant macular edema, which we initially used to document and do according to before the development of an OCT. But then what is the effective strategy to treat a macular edema? We all know it is a multifactorial disease. There are many things which are involved in the pathogenesis. So we cannot take one factor into the consideration. We have to take all factors, and then we need to individualize the treatment. And it has been said and seen that 30 to 35% of the patients, they resolve spontaneously if you see them for 6 months. And treatment, which one is very important, but what we discussed is to a good control of diabetes. But then that good control of diabetes in the initial years are very important. So when you start the treatment and if you reduce the HbA1c, it will reduces the risk of retinopathy by 30 to 40%. So our patient will be for the prevention because of the metabolic memory. They will not develop or progress to a diabetic retinopathy. So the first line of treatment is not only to control the sugars, but also to control the blood pressure, lipids and associated pathologies, which will control the disease and the edema by 35%. And then there are various studies which is being discussed, that there are so many studies which come across giving us the importance of each and every aspect of treatment of diabetic maculopathy. As said, central involving with anti-VEGF, steroids and anti-VEGF in combination, or vitrectomy when there is a taut hyaloid membrane, or lasers when there is a non-center involving macula. So what is the role of laser? So when we had that ETDRS study, which was a very rigorous multi-centered randomized trial, which shows us the benefit of DME, which reduces the risk of loss of vision in 50% of the patient, but it was minded 3 years as compared to a control. And it is being said that the mainstay of the treatment of diabetic macular edema is lasers before this trial came in 1985. And only there was a 3% gain. That means the vision gain is not our priority. Our priority is to stabilize the vision. So what are the parameters which are being used? The focal lesion, it is in the ETDRS, it is a spot size of 50 to 100 microns with 0.05 to 0.1 second, and in the grid laser in a pattern of grid on a temporal side with 50 to 200 microns with a duration of 0.05 to 0.1 second. And the mechanism is basically to reduce the oxygen to the retinal areas and destruction. So the side effect is that they will extend and they will create a central loss of vision and central scotoma, and they alter the vision, and they may incite into a neovascularization and subretinal fibrosis. That is why the modified ETDRS techniques are a mild macular grid techniques came into the consideration, but then this being replaced by anti-VEGF when we had these anti-VEGF multiple trials, but then all those trials which are being shown here, the RED trial, the RESTORE and the many other, they are all showing the importance of using an anti-VEGF in macular edema, but they have not told us the answers for macular laser for such patients. And most of the studies in this paragraph number 3 can say that it is being studied only for 1 year. So we have been seeing the efficiency for 1 year, not for the 2 and 3 years, which ETDRS study has done it. And then many of these RCTs, they are being done in a controlled environment for the center involving, but we know that our DME patients, they are not having a single phenotype, they have a different morphological variabilities. And then we know that most of the studies, there could be a leaking microaneurysm outside the fovea, and in RESTORE trial themselves also, 33% of the patients, they show the leaking microaneurysm outside the central zone, which needs the laser. And even the sub-analysis shows that the retinal thickening of more than 300 micron, they responded very well to the macular lasers. So not only this, but then we have not studied the non-center involving macular edemas. So parafoveal macular edemas definitely needs a laser. Even in the DRCR net protocol V, they have said that you observe the patient, but in 36.7% of the patient, when they observed and if they subsequently develop the macular edema, vision loss, their vision progressed to the worse, and they had a poor visual outcome in spite of giving the anti-VEGF. This is probably because of the long-term photoreceptor damage. So that is why we have to do a laser treatment for non-center involving macular edema also to protect the vision loss for the future. So all these studies, they are well designed with a regular follow-up, which we don't see in our normal clinical scenarios. 25% of the patient may lose to treatment or may lose to a follow-up. So if there is a non-compliant patient, especially non-center involving macular edema, why not to give a laser, and it is a viable option to prevent the vision loss. And even the DRCRS net protocol T has been showed that intensive anti-VEGF therapies under the trial condition, the macular laser treatment still needed in 37 to 56% of the center involving macular edema also during the first year of the treatment. And then not only this, there are many issues which are there with the anti-VEGF. There are few patients which may not be responsive to multiple injections. There could be a macular atrophy, and there could be a risk of complication, though very small, but then endophthalmitis, retinal detachment, and even the strokes. So what is the role today? So definitely it is having a role as an adjuvant therapy or synergetic activity with the anti-VEGF. There will be a greater reduction and the long-lasting effect. So if you want to have the improvised effect, it will be more with the lasers, and they will require the number of injections lesser in comparison to when you give anti-VEGF alone. So combination therapy definitely works better, and the amount of the laser energy which is required when you do a combination therapy will be lesser, so the complications related to the laser will be lesser. So in present scenario, the lasers can be used for the focal diabetic macular edema. The grid will be used only for resistant and contraindicated cases where we cannot use anti-VEGF. But then we have to simplify the treatment because multiple follow-ups may not be possible with our patients, and also the concern of the cost. So we have to do a laser, and then we should think of a newer laser technologies like sub-threshold macular diode laser, selective laser therapies, so that we should avoid the destruction more to the surrounding retina. And the selective laser diode micropulse therapy is very promising. It reduces the amount of the damage to the retinal pigment epithelium, and it is very fovea friendly. So you can do even the foveal lasers. It has a repetitive effectivity, and the TXL guided micropulse therapy also help in settling the size and the duty cycles. So because of that, the damage is not to the extent of higher density applications, and we can also have an image guided photocoagulation. So to conclude, the monotherapy macular laser treatment, though it has lost its role as a gold standard treatment, but it has an important role in combination with anti-VEGF and the grid laser in resistant and contraindicated cases where we cannot use anti-VEGF. And macular laser is going to stay, and it will be in the different form, maybe sub-threshold or many other good lasers. Thank you so much for patience listening.
Current. Thank you, ma'am. Vinita, ma'am. You have taken lasers so bright, so nicely. And I remember one of the famous retina surgeons saying in one of the meetings that I do more lasers than required, and I don't leave a chance to use laser if required. Dr. Dudani has also joined in, and Dr. Saurabh has also joined in. They were in different slots, so they came a bit late. Dr. Saurabh, you are, I think, ready with your presentation. So before you start your presentation, I'll give you a cap.
Good afternoon, everyone. I thank Dr. Malay sir for this opportunity, and it's a pleasure to be part of his IC, which is on basically DME, AI versus the manual analog. And so I'll be talking on intravitreal injections in DME and DR, which one and how much. So we know that DR is a common progressive microvascular complication. I'm sure you've heard about this. And what is DME? It's characterized by abnormal accumulation of fluid in the intraretinal and subretinal space. And the correlation of diabetes is it has a correlation with the duration and also with the severity and the visual acuity. So we know the biomarkers of DME. They are various. So they can be cystoid macular edema, and we have to see the retinal thickening. And also we have some newer biomarkers like DRIL, which is dissociation of the retinal inner layers, and also the integrity of the ellipsoid zone or the ISOS junction. So we all know that there is microvascular damage due to breakdown of inner blood retinal barrier, which causes leakage of fluid from the blood vessels and macular edema, and hence the importance of VEGF and using anti-VEGF agents for these. So what are the deciding targets for DME management based on disease progression? So DME management aims reduce the amount of macular edema, reduce the leakage on FFA, reduce the thickening on OCT, and to improve or stabilize the vision. And this is just an algorithm which shows how the presence of edema decides the protocol for the management of DME. And as I was saying, that these are the various newer biomarkers for DME, like hyperreflective dots or spots, and DRIL, and a sub-neurosensory detachment, and also the ISOS integrity, and also the choroidal thickness. In fact, choroid is more and more becoming more important, and choroidal thickness, and not only choroidal thickness but also choroidal vascularity index, which I won't go into detail, but it is also becoming very important in management of DME. So this is how the evolution of DME has happened, and I'm sure the earlier speakers have gone through this, where we just heard ma'am talk about laser and how it is still in some conditions a gold standard for diabetic macular edema. But we now have the various VEGF inhibitors which are available, including the steroid implants, which are the fluocinolone and the dexamethasone implant. But as I will show you in my next few slides, how molecules like, I don't have any financial disclosure, but how molecules like aflibercept score over the other molecules. So this is the EURETINA guidelines for the management of DME, and which says that as a consequence of recent rigorous clinical trials, laser photocoagulation is no longer recommended for treatment of DME, and anti-VEGF has emerged as first-line therapy, and aflibercept is the drug of choice for DME in patients with baseline visual acuity below 69 letters. Another expert guidelines from Asia which show that anti-VEGF therapy should be given as a first-line treatment for patients with center-involving DME with central visual loss, and choice of anti-VEGF depends on the baseline visual acuity, and early intensive anti-VEGF therapy is important for patients in Asia. So this is more region-specific, if you may call it that. And this is the evidence-based medicine pyramid. When making evidence-based decisions for patient care, it is essential to select the highest level of research design, which we know is basically a systematic, review is the lowest, but the higher the randomized control trials are, quite high up there. So in fact, systematic review is the highest, and the editorials and the case series and case reports are the lowest. So the Cochrane meta-analysis, which is supposed to be the highest level of evidence, it showed that all efficacy outcomes significantly favor aflibercept over either comparator at year 1. And it also showed that it conferred an advantage of best corrected visual acuity over ranibizumab and bevacizumab at year 1. The PAT survey, which is again a very respected survey in the American Society of Retina Specialists, it showed that aflibercept is considered the treatment of choice for new onset DME, according to a recent survey of participants. So in India, the treatment of naive DME with aflibercept is just coming in. Not many patients can afford aflibercept, but with the patient support program, I think things are changing. Protocol T from the drcrnet.net was a randomized head-to-head trial of anti-VEGF treatment for visual impairment due to DME, where it compared 2 milligrams of aflibercept versus bevacizumab versus ranibizumab. And so this was the study pattern which was there, but I will just quickly, because of in the interest of time, I will just show you what we found. That it was patient was they therefore received approximately 6 monthly doses, and aflibercept was found to be better than bevacizumab or ranibizumab at the year 1. Initial vision gains with aflibercept were maintained to year 2 with the need for fewer injections than in year 1, and it was associated with rapid and robust anatomic changes that were superior to those observed with both comparators. And it was also maintained through year 2, which is the most important thing. So among eyes with persistent DME at week 24, continued anti-VEGF treatment decreased the probability of chronic persistent DME at year 2. So intensive anti-VEGF treatment in year 1 may facilitate a reduced injection burden thereafter. So the basic idea is to hit the DME hard initially, if you want that the number of injections should be less in the years to follow. So we have seen from various analysis, meta-analysis, and from in various forums that they have vouched for aflibercept's superiority for the treatment of DME. The new kid on the block, brolucizumab, is the smallest known active unit of antibody that allows for concentrated molar dosing. We know that it is a short chain fragment, and it is a very small molecule compared to the other anti-VEGF agents. So each 6 milligram injection delivers a 12-fold higher molar dose than aflibercept in the same volume, which has the potential to deliver durable efficacy with less frequent dosing. And it was the first single chain antibody fragment approved for use in ophthalmology. And these are the various studies. I won't go into the details of these studies, which were the Kestrel and Kite. And up to week 52, they have been studied. And the phase 3 is still ongoing. And they found that brolucizumab was a very useful molecule for treatment of DME. 6 milligram was non-inferior to aflibercept in mean change in BCVA at week 52, significant improvements in central subfoveal thickness, higher proportion of patients with fluid resolution, and more than half of these patients were maintained on Q12 week treatment. So that is the most important thing for retina specialists, is to how to increase the interval duration between injections, because how to reduce the injection burden. Here it says overall brolucizumab had a well tolerated safety profile. So that has been the question mark for brolucizumab, which is still not clear and still not totally solved because of some inflammation issues that were found with brolucizumab. So just a few cases. So high risk PDR in the right eye, moderate NPDR in the left eye. Already this patient had received PRP and various injections, Lucentis, Eylea, Ozurdex in the right eye, and Lucentis and Ozurdex in the left eye, and had CME. And you can see how that after every anti-VEGF injection, it responds, but then the swelling comes back. So this was way back in 2016 and 17. In 17, this patient was switched to Ozurdex implant, which is a dexamethasone sustained release implant. He does well, but again, the swelling has a tendency to come back. So in 2018, when the patient was seen, the vision was down to 618 again, and there was a recurrence of the CME. At this point of time, maybe because of we wanted to rule out tachyphylaxis, patient was put back on Lucentis again. Patient responded, had a cataract surgery. And then finally, again, patient started having recurrent CME. At this point of time, we switched the patient to Eylea in 2019. And subsequently, patient did well, but had a few recurrences. But subsequently, we just managed to stabilize the patient on anti-VEGF injections. And aflibercept has this additional longer-term action, so it is more useful than the other agents. And you can see the seesaw effect of anti-VEGF agents here. This was the second case, and in this the patient had deranged blood sugars, and also had a creatinine of 5.6, which is another thing which we have to remember is the systemic profile, because this patient clearly had nephropathy with a urea of 124 and a creatinine of 5.6. Had multiple injections, initially was stabilized with PRP and anti-VEGF injections, but was kind of lost to follow-up during COVID, came back again with recurrent macular edema, and was finally stabilized with aflibercept. Third case was another 70-year-old male, type 2 diabetes, and again had multiple, you can see here, multiple anti-VEGF and implants. And this is how the patient progressed over the years. We used to stabilize with repeat injections and repeat implants. But what is important here, if you can see here, I'll just quickly conclude, is the steroid response. You can see that this patient turned out to be a steroid responder not after the first Ozurdex implant, but after I think the second or third implant, that there was a steroid response seen in 2017 when patient was again put back to Lucentis and finally was stabilized on Eylea. So this is just to show that it's just like cancer chemotherapy. We have to keep working with these agents, keep switching between agents, and sometimes we get the response with an anti-VEGF. Sometimes we have to use steroids, then again we have to come back. So it's a never-ending process sometimes. But I have seen in my experience that eventually after 2 or 3 years of regular anti-VEGF treatment, these patients finally stabilize, provided their systemic condition is under control. So with those words, I would like to thank Dr. Malay sir for this opportunity, and invite Dr. Ajay, who's the next speaker. And this is a photograph which I showed in the end. Was Dr. Abhijat just finished recently his VR fellowship with us, and it was a pleasure to have you.
I'll just be speaking to you very briefly. I just have 5 minutes. So can I have my slides, please, if you don't mind? So I think it was basically covered. Everything has been covered. So importance of early diagnosis is very important in diabetes. And patient's journey starts from screening to diagnosis and then to monitoring. So fundus photography, as has been discussed before, is the gold standard. And with AI coming in, fundus photography is basically available, non-invasive, and it shows all the features of diabetic retinopathy. Fluorescein angiography is getting less and less popular because of the non-invasive things. So the disadvantage is the invasive and the time consuming, but I think this shows the extent of diabetic retinopathy the best vis-a-vis anything else, you know. So you can see the exudates, the Cotton-wool spots, and with the ultra wide field angiography, it's all the more better. But OCT forms the gold standard is what I feel. And it shows the normal retinal structure. And today we have come up with this extensive high definition scans, almost a lakh A scans per B scan, and it's non-invasive. It gives an in vivo cytology of the retinal structure. You can see the hemorrhages, you can see the intraretinal cysts, you can see the microaneurysms, you can see the neurosensory detachment, the retinal swelling. And now we are getting more and more into this EZ zone disruption and the external limiting membrane affection which is there. This is a very severe DME which we see, which is a complex DME with subserous fluid which responds very beautiful to steroids in my hand. So these are the biomarkers on OCT which have been proven to show, you know, retinal thickness leads to damage to the bipolar axon cells. So if I have a spongy retina which is thick and fat, will lead to reduced visual signal transmission and poor vision in these patients. So CST has been the biomarker in all the studies which we know. So the type of fluid which we have is the breakdown of the inner blood retinal barrier. And when you have subretinal fluid, it's in the late stage of DME. Normally we get IRF or intraretinal cysts, and these cysts usually respond very well to anti-VEGF treatment, and they are suggestive of the activity of DME in most of the cases. Chronic DME can lead to, you know, irreversible damage, and this is how the retina looks on, you know, photographs which we see here. And don't forget laser, as ma'am said very beautifully. I always, even today, do a focal macular laser in my patients because all patients can't afford constant injections. The cost is what is the problem in India. So there's a way which the trials work and the way real life works. I think, you know, combination therapy works better for all diseases. So this is another sign which we have called as drill, where you're seeing there's a total disorganization of the inner retinal layers with the hyperreflective foci. So how do you differentiate HRFs from hard exudates? HRFs are much smaller. They will not cause shadowing vis-a-vis the hard exudates will be larger, and they'll cause shadowing behind over the choroid. So this is all I wanted to thank you all for your kind and patient hearing and giving me an opportunity to speak to you all. I was brief, sorry, but this constraint of time.
Thank you, Ajay. You have been fabulous always. And before we end the session, I would like to have Dr. Kamaljeet Singh sir to have his final words, which are of utmost importance. Now.
Finally, we have come to the conclusion कि हमारे देश में टेम्पो भी चलेगी और इम्पाला भी चलेगी. So you need laser photocoagulation, as most of us agree. And in our setup, like I work in a government setup where we have patients who cannot even afford triamcinolone. And in my practice in MDI hospital, 80% of the patients receive triamcinolone, 2 milligram. Once we give and then do laser photocoagulation, as we were talking about combination therapy, 80% of the patients. And if we don't do that, when they come back with very severe PDR and hemorrhage. They don't understand that they would become blind, and therefore a combination treatment in Indian scenario is very good. Secondly, about PDR and high risk characteristics that we discussed many times. In our setup, we have to give do a pan-retinal photocoagulation in severe PDR itself. If the other eye is involved, we must not wait for the patient to develop into high-risk characteristic because the follow-up is so poor. You will do laser once, the patient will not come in time, and if you have not done laser photocoagulation timely, then the patient will become blind, and that would be a worst thing to have. So these are some of my thoughts that in Indian scenario, if the patient has come to you, we have to do laser photocoagulation early. And if he cannot afford anti-VEGFs, then we must give triamcinolone. And I tell you that glaucoma incidence has been unnecessarily quoted that it's too high in 2 milligram dosage. As somebody was mentioning, it is 10 to 12% only. So it's very rare, and some of the drops can solve the problem. Even surgery may not be required in most of the cases. So with these few thoughts, I would like to finish off here. Thank you so much.
Thank you, sir. And I think we are in time. We hand over, we'll have a photograph together and then we'll hand over the mic, sir. I think आपका session, sir.